Okay. Yeah. Tumors of esophagus, they are benign and malignant. There are two types of tumors, benign and malignant. Okay. For benign tumors, the most common is leiomyoma. Leiomyoma is the most common. And site, some books say it is middle third, some books say it is lower third. Okay, but remember it is in the lower third, lower one third. And CECT is investigation of choice. Treatment is for benign tumor, resection is enough. Endomucosal resection or resection of the tumor is enough. So this is about benign tumors. We go into malignant tumors. Malignant, most common site is middle third again. Malignant, most common site is middle third. We divide the esophagus into three parts, upper, middle and lower. So middle third is the most common. And most common type in India is squamous cell carcinoma. Most common type in the world is squamous cell carcinoma. Most common type in the Western countries is adenocarcinoma. Why this difference is because of the food habits and the presence of risk factors. Okay, because of that, the difference is there. So most common site is middle third. In the middle third, it is most common, and squamous cell carcinoma in India, squamous cell carcinoma in the world, and in the Western countries, it is adenocarcinoma. So,
just a sec. Can you please show the previous slide? Sorry.
This one?
No, the one before this. So the site point of view, I didn't get it.
Site, it is middle one third or lower one third, but it is a little ambiguous. In Bailey, it gives as middle one third. In higher books, it is given as lower one third. So that's why it is little ambiguous.
So esophageal adenocarcinoma is distal one third, sir, or middle?
Here, adenocarcinoma is, most common site of malignancies is middle one third.
Okay.
Okay. Yeah. Is it okay, this slide?
Yeah, got it, sir.
Okay, this is over. So now risk factors. Risk factors for squamous cell carcinoma. One is smoking, alcohol, eclasia, Plummer-Vinson syndrome, corrosives, low socioeconomic status, tylosis. Tylosis is, it's a autoimmune disorder type of thing where there will be abnormal fibrous bands. Okay, tylosis. And coming to adenocarcinoma, see the risk factors here: GERD, Barrett's, obesity, smoking, scleroderma, high socioeconomic status. Okay, this is all related to the Western countries. High socioeconomic status, GERD, obesity, smoking, these are all the risk factors there. Whereas in poor countries like in developing countries, like socioeconomic status is where it's low. Smoking, alcohol is very predominant. Eclasia is predominant in our country. So squamous cell carcinoma is the most common thing in our country. Clear? Yes?
Okay, sir.
So what is the clinical feature? Before this, what is the clinical feature of bladder malignancy?
So is hematuria present?
Painless hematuria.
See, I told you some things, right? It's not only hematuria. There are two adjectives you had to add before. Two adjectives. It is hematuria, yes. But what is that? Painless hematuria, one. And the other is it gross or it is microscopic?
Microscopic.
No, it is gross hematuria. Gross painless hematuria. Okay. That is the classic description of bladder cancer. In the same way, for esophageal cancer, it is dysphagia. Obviously, the patient cannot take solid food. Dysphagia, and it is rapidly progressive. If the question gives a 60-year-old male comes to you with rapidly progressive dysphagia, then your answer should be CA esophagus. Okay. Yes, no?
Okay, sir.
Yeah. And
like rapidly progressive means onset patient will not be feeling hungry, right?
Yeah, the onset is very fast. See, the patient, suppose he'll feel like there is something obstructing, and next month he will not be able to take even a single water drop also. That will be the spread of rapidity. Okay.
Okay.
Yeah. And then rapidly progressive dysphagia. It is both present for solids and liquids. It is present for both solids and liquids. Okay. And in most of the cases, what will happen is they form tracheoesophageal fistula. Because of this malignancy, it is tracheoesophageal fistula. And these patients are inoperable. In some cases, they will become inoperable. Okay, we have to give only other modalities. We can't operate in them. And remember one thing: in eclasia, it is more for liquids than solids. Liquids than solids. In cancer, it is solids than liquids. Why is it so? Just think and tell. This is a cancer mass, and the sphincter is narrow. This is eclasia. Just think and tell me. This is an important point. Why solids and liquids and solids?
Liquid can't pass.
So in
Oh,
cancer,
eclasia.
actually, because there's a tumor formed,
Yeah.
liquid can seep through, but solid would not be able to do that.
Okay,
And
so
echalasia-
solids. Yeah.
And in echalasia, because the sphincter is so tight, because of the pressure of food, it may seep through, but liquid may
Yeah.
not.
Very good. Liquids, they are less. They are of less weight. Solids have more weight. Because of this, they will seep. Liquids, solids try to seep through the sphincter, but liquids, because of the low weight, they will not make the sphincter open. Okay. So eclasia, it is liquids more than solids, and carcinoma, it is solids more than liquids. That is one difference. And second is in barium swallow. What is that in eclasia? What is that you found in barium swallow?
It's bird beak
Bird beak
appearance.
Bird's beak appearance. In the same way, in carcinoma, it is rat tail appearance. Rat tail appearance. Suppose this is the esophagus. If this is the contrast, there will be little contrast only going because of the obstruction. Okay, so it is rat tail appearance. Rat tail appearance in carcinoma. So this is all not necessary. So here, how to investigate? You tell me how will you investigate?
First would be a barium swallow.
Yeah, barium swallow.
And if then we would do an endoscopy plus a biopsy.
Okay.
And for staging, we would do an endoscopic ultrasound.
Okay.
And for if it is in order to differentiate between the obstruction and malignancy, we will do a CECT.
Yeah. Okay. So see here, very good. So investigation of choice to diagnose. We need to know whether it is malignancy or not. To diagnose, it is an endoscopic biopsy. Put a endoscope, take a small chunk of tissue. It is an endoscopic biopsy. For investigation of choice to diagnose it, it is endoscopic biopsy. For staging, there for T, for N and M. What is T? T is tumor. What is N? N is node. M is
Metastasis.
Mets. So for T and N, it is endoscopic ultrasound. You just put an ultrasound and you can know the depth of the spread or not. So for T and N, you can just use the endoscopic ultrasound. It is enough for T and N. But for M staging, for metastatic staging, you need to do a PET CT. Okay. But if in the question they give you what staging, only staging completely, like they don't ask for T staging for M. The questions come like esophageal cancer, the investigation of choice for diagnosis, that is biopsy. The investigation of choice for T staging, that is endoscopic ultrasound. For N staging, that is also endoscopic ultrasound. If they don't give anything, just they ask you overall staging, what is the investigation of choice for staging of esophagus? Then it is CECT thorax. CECT thorax. Okay, clear? If they ask specifically, that above one, T, N, and M. If they don't ask specifically, it is overall. It is CECT thorax.
Okay, sir.
Yes? Okay. Management. First, we will discuss. Most of the times, this is inoperable cancers because it has spread to the adjacent organs. It has inoperable cancers. In inoperable cancers, we have options like, anybody, what is this SEMS? What is FJ? Anybody? Are you able to follow? Inoperable, I means, operable means which can be resected completely. Inoperable is it has spread, the lymph nodes have spread, or it has metastasis, or it
Stent or
esophageal fistula
something?
is from. Yeah. Remember, see this is important. SEMS is self
Expandable.
expanding metal stent. Self-expanding metal stent. There is a small stent available. You put it in the esophagus. It expands and it makes the esophagus open so that we can extend the life of the patient. Okay, so that we are not removing the cancer, but we are just allowing the patient to take food for the purpose of nutrition. So this is self-expanding metal stent. And what is FJ?
So is it feeding jejunostomy?
Very good. It is feeding jejunostomy. This is all inoperable, right? So just we have to prolong life by giving some feed. So this is the stomach, this is the esophagus stomach, and this is the bowel. So we'll open the abdomen, we'll put a small tube here into the jejunum so that we can feed the patient directly through the jejunum. Okay. And with the help of laser, we can make a small opening and we can put some tube inside. So these are all ways to increase the nutritional demand, to meet the nutritional demand of this patient. Self-expanding metal stent, feeding jejunostomy, and laser. Suppose if it is operable, so what we should do? What is the treatment? In the first slide I told you. Can we do a partial resection?
No, esophagectomy then.
No, we
Yeah.
can't do that.
Yeah, we can't do that because there will be serosa is absent. So we have to resect the esophagus completely. 10 centimeters and 5 centimeters, whatever is available, we have to resect it. And we have to remove the lymph nodes also. Lymph nodes for esophagus, it is strangely in 3 locations they are there: in the neck lymph nodes, thorax lymph nodes, abdominal lymph nodes. For other malignancies is okay. See, for breast we removed only the axilla. For testis we removed only the inguinal. But here the esophagus is having 3 stations of lymph nodes: one in the esophagus, one in the neck, one in the thorax, and one in the abdomen. So we have to remove all these lymph nodes. Clear this point?
Clear, sir.
Yeah. And what are the various types of esophagectomy? Once we can do transthoracic, we can open the thorax, we can do here, or transhiatal. From the abdomen, open the diaphragm, and we can go from below also. 2 ways: transthoracic and transhiatal. Okay. No need to know these names, but just for the Ivor-Lewis 2-stage operation, McNeon 3-stage operation. So, and transhiatal is Oringer's operation. They are just the names for that. But just remember, esophagus, remove the esophagus totally. With 2 approaches: one is transthoracic, second is transhiatal. And lymph nodes are removed from 3 stations: cervical, abdominal, and thoracic. Okay. Then you have removed the esophagus. So this is the pharynx here. This is the esophagus you have removed. This is the stomach. So what will happen to that after the surgery? What will happen to the patient?
No feeding tube is there. So
Yeah. So there is no channel for food to pass. So what you should do after esophagectomy? Every time you have to do some
Anastomosis.
anastomosis, reconstruction or anastomosis. You have to do reconstruction or anastomosis. Okay. So see here. So we use some things called conduits. Like yesterday and day before yesterday, we thought we are studying when we remove the bladder, we are making it ileal conduit. So the best conduit is the stomach. So stomach, a small chunk is removed and it can be replaced. Okay, or it can be mobilized like a tube inside the thorax. So the best conduit is stomach because it is highly vascular. Stomach has a lot of blood supply, highly vascular. We can easily form a stomach. Best for long segment. If you need a long segment, total esophagus is removed. If you need a long segment, then colon is the best replacement. For short segment, jejunum is the best. If you need a small short segment, for jejunum. And for gastric conduit, it is dependent. The conduit depends upon right gastroepiploic artery and the right gastric artery. These right, based on this right gastroepiploic and right gastric artery, the conduit is formed. Clear? Best is?
So last slide, 1 second, please.
Yeah. So which is the best conduit for esophagus?
Stomach.
Okay. For long segment, it is the colon. Remember these two. And gastric conduit, the blood supply, it is dependent upon the blood supply from the right gastric epiploic and the right gastric artery. Okay.
Okay, sir.
Yeah. And next, coming to the root. Okay. You are preparing a conduit. So how to prepare the root? Suppose, see, there is a skin here. Beneath the skin, there is the sternum bone. Sternum. This is the bone. This is the skin. This is the bone. And beneath the sternum, there is the esophagus, which is not there now. There is empty space. Esophagus. Sorry. We know that there is the heart. And below that, there is the esophagus, which is not there. This is the anatomy, right? So you want to reconstruct the esophagus. So the posterior mediastinum is the best root, shortest root, and most dependent. The posterior mediastinum. You can do the reconstruction here. Posterior mediastinum, the best root. Substernum, beneath the sternum also you can do. And subcutaneous, on the sternum if you do. But why we don't do on the sternum? Subcutaneous route, why is less commonly used?
There is no guarding for the esophagus.
Yeah, no guarding, and one more thing, it is very awkward looking, right? See, if there is just beneath the skin, if there is esophagus, if there is a tube, it is very awkwardly looking. So either you prefer a substernal route or a posterior mediastinal route. Posterior mediastinum is the best route because it is very short route. For us, it is easy to anastomosis it. Okay, posterior mediastinal. The best conduit is?
Stomach.
Best route is?
Posterior
mediastinum.
Mediastinum. Okay, remember these 2 points.
So can you explain the picture just once again? Just
yeah. See, normally normally here, if you look from here, go back. First there is skin. Skin is there. Beneath the skin there is sternum is there. Then heart is there. Heart, and then the esophagus is there, and the mediastinum is there. Okay, this is the level, right? Skin, sternum, heart, esophagus, and mediastinum. Now the esophagus is not there. You have removed it. So you have to reconstruct it. So what are the ways which we can reconstruct? One is subcutaneous. Beneath the skin you can reconstruct subcutaneous. Beneath the sternum you can reconstruct substernum. Or beneath the esophagus, here you can reconstruct. This is posterior mediastinum. This is the best route. Posterior mediastinum is the best route available. Okay?
Okay.
Yeah. So now we will move on to the stomach.